And good evening and welcome to my YouTube channel Pain Free Partha, and we will talk about principles of TIVA and slight touch on TCI. My channel Pain Free Partha. So total intravenous anesthesia. It refers to the technique of giving patients IV agent to anesthetize. No agent, volatile agent is not given. That is what is given. Ultra short acting propofol, fentanyl, dexmed, etc. Why should it come up now? To go to the history, Franz Rin developed the hollow needle. We need to have a needle found out first. Needle invention is necessary to give TIVA. So in 1872, this reported a chloral hydrate as intravenous anesthetics. So this was the syringe used then. A lot of work on this was going on during TIVA and COVID because we were afraid of putting the tube and giving agents in those damaged lungs or infected lungs or probably transmitting infection lungs. So this TIVA became a big boost during COVID. Now, why more the push now? Newer drugs with short duration of action, and we have got a lot of advanced technology, a lot of AI coming in. That is why the push. Obviously, TIVA is there. TIVA may be provided either by an insertion of ET or an LMA or a oral airway or a simple mask. All these things are possible. It means only there is no agent, inhalational agent used. Give propofol, give scoline or give a trachurium, put tube, continue in propofol. Fentanyl, whatever it is. This is what is the TIVA. It doesn't mean there is no endotracheal tube or anything like that. In the field of neurosurgery first, then into daycare, then so many procedures. Now, what are the indications? Yes, we have malignant hyperthermia risk, long QT, history of PONV. So one of the best things, PONV reduction in TIVA. Tubeless ENT and thoracic surgeries, because sharing the airway. The ENT surgeon tries to remove the foreign body. We have some jet ventilation as giving oxygen or something like that. Then where will be the anesthesia? It has to go to propofol, TIVA. Anticipated difficult intubations, neurosurgeries, neurophysiological monitoring. So what will patient choice? Daycare surgeries, trainee teaching, that is how we learned. For example, now a simple hernia is there, done under spinal anesthesia. Start propofol, TIVA, 1 point, or TCI, 1.5 mics per ml in the effector site concentration. Do that. What happens? All these things. Yes, this is also an indication of TIVA, TCI. Now we know what is TIVA. Total intravenous anesthesia, no inhalational agent. Now, what is target controlled infusion? What is target? Now, brain is the target. Plasma is the target. We want the plasma concentration to be like this. We want the brain or the effect site concentration to be this much. This is what is called the target controlled infusions. You tell the pump that I want a target concentration of 4 mics per ml in plasma. It automatically adjusts. It gives bolus infusion rates. How it does? It has been taught to follow a pharmacokinetic model. It knows the model of propofol. It knows the pharmacokinetics of propofol. So you push in, march, and then touch. Now we will know the difference about TIVA and TCI. It is manual. TIVA means you start with 8 milligrams per kg per hour. Then the next step is 6 milligram per kg per hour. It's manual. It is automated, model-based. It is based on clinical science, BIS and chemodynamics. Bispectral indexes decreases. Standard syringe pump is enough. Do we need to have a TCI pump with a model inbuilt? So it's variable. It is more consistent. Variable means it depends upon me. I can put 6 milligram per kg per hour, and the next anesthetist may put 5.5 milligram per kg. So this is fits into the model. This is the difference between TIVA and TCI. All TCI is TIVA because target controlled infusion means we are giving IV only. We are not giving agents. So, but not all TIVA is TCI. We mean this is pump. We have started age, height, weight, and sex to be given to the pump to give the target effect site concentrations. It has got a computer, it has got an infusion pump, and there is an interface. So the computer analyzes this and gives. Now, what is context sensitive? Context sensitive, context means duration of infusion. Context, what is the context here? Context is duration of infusion. Now, propofol is given for 3 hours. Duration of infusion 3 hours. Now you stop the propofol. What is the concentration now in plasma? For example, it is 10 nanograms per ml. How much time does this concentration comes down to 5 nanograms? It may be 8 minutes, 10 minutes. This is what is called the context sensitive half-life. This may vary because if you give the infusion for 10 hours, it may vary. If you give the infusion for 2 hours, it may vary. What do we need actually? Even if you give 10 hours infusion, half-life should be small. The concentration should be come down to half within 3-5 minutes or within 8 minutes. That is what we want. That is what is called context-sensitive half-life. So you can see here, even after 10 minutes of infusion, see here, half-time is 200 minutes. Now you go thiopental. Now you go fentanyl. As long as you stop at 2 hours, it is okay. But if the duration of infusion is 4 hours, think it's half that is 150 minutes. Dexmedetomidine, it is around 40-50 minutes. Now here you see remifentanil and propofol. If you stop at 2 hours, it is around 10 minutes. If you stop at 5 hours, it's around 20 minutes. If you stop at 7 hours, also it is 20 minutes. 20 minutes. After 7 hours of duration of propofol infusion, the half-life of half-life is only 15-20 minutes. That is what we want. Now, what we want as TCA or TIVA, we want to have very short context-sensitive half-life. That is propofol and fentanyl. Now we have Marsh and Schneider models in propofol. Marsh means patient, you enter the weight, it will calculate the PK parameters, select the concentration. I want the concentration to be 4 mg per ml in the brain. Start infuse, start press. Schneider model, you may need to give age, sex, height, lean body mass, all these things. It is not only weight dependent. So that is the advantage in elderly. This Schneider model, better suited for elderly. Effector site concentrations. It's a more complex PK model. Marsh model is simple. This is more complex. Now something like that, Marsh one size fits all dosing like this. But Schneider is more tailor-made for effective site. There is one more model called Elivel model, is a newer pharmacological model for propofol, fentanyl, and sulfatanol. Incorporation of age and weight. If we don't have anything to have the patients with diabetic, hypertension, old stroke, dementia, Alzheimer's disease, all these things are not there. That is where we stand. So, coexisting medical illness, what is the position? All these things cannot be entered into these models. Now I will go to propofol. This is TIVA. You start with around 6 to 8 milligrams. You can see here 8 milligrams per kg per laryngeal mask or 10 to 12 surgical anesthesia. This is what is. Now we can see the target controlled infusion. Normal sedation is 1.5 mg. The patient, if you want to do some other under block, now you start your propofol as 1 to 1.5 mg per ml. As TCI, patient will be well sedated. Okay, we have given blocks, but we have also given this TCI sedative dose. Surgical anesthesia is 4, around 4. Deep anesthesia is 6. This is red. So normally 8, here it is 4. to 3. Suggested effectors are here. It may vary with spontaneous or IPPV. Sometimes it may change. Propofol may be 4 to 6 in spontaneous, and in IPPV it may be 3 to 4. So there are a lot of combinations available. You can add remifentanil and propofol. You can add propofol, fentanyl, and dexmet. Ketamine, propofol. Ketamine with dexmet. So many. Dexamethasone, magnesium, lignocaine, pentaketone, intermediate with fentanyl, ketamine with midazolam. So many are there. Ciprofol is a new IV agent. Rapid onset recovery. It is 5 times more potent. Does not cause pain. Yes, you can use ciprofol also. You can use remimazolam, ultra-short acting, rapid hydrolysis by tissue esterases. That is where this remi comes. Sedation and total intravenous anesthesia. Even better than midazolam because it is ultra-short acting, rapid onset of. We can combine like this. One is propofol and another is propofol. This is propofol and that is remifentanil. If you want to combine propofol and remifentanil, sometimes we may need to use anti-siphon drains, anti-reflux valves because this propofol should not go here. This propofol should not go here. All these things should be there, and there's a good lower lock so that it doesn't disconnect itself. Now we have given that. How to know that this is achieved that? Loss of response to shaking and shouting. Loss of hemodynamic response to limb movement with vigorous jaw thrust. Absence of tachycardia, bradycardia with laryngoscopy. All these things tell we are in that plane. But already intubated patients, we may need to have a BIS of around 40. Means patient is anesthetized well, around maximum of 60. Most of the anesthetic drugs follow 3 compartments. If you go bolus, central compartment is plasma, rapidly equilibrating. That depends upon the constant. Rapidly equilibrating is muscle. Slowly equilibrating may be fat and bone. This is the brain. So it will get eliminated. Now, if you want to give bolus, you may need to maintain the concentration. Means what all you may need to know. You may need to know this. You may need to know this. You may need to know this else. So that how much goes here, how much goes here, how much goes here, so that how much will go here. That is what is. C1 is a central blood compartment. C2 is highly perfused. Let's move fast. Now the effective site is brain. If you know this, we know bolus elimination transfer. But bolus is given, plasma is. Then how much to replace? How much it goes through this outside the central compartment? Now there is a compensates for the loss of peripheral compartments. It reduces over time as the levels equilibrate in the compartment. Now it has to go to the brain only. Now the infusion may be little less. What is the best model for elderly? I have told Schneider model is better. While it gives a large induction dose, total volume is less. Whichever mode is selected, a lower target concentrations. So the example, if your target concentration is 4 in routine adults, you may be 2.5 or something in elderly. The use of TCI in children is a specialized area of practice. Pedifusar, Kataria pumps models are available. If the patient is above 16 years, above 60 kg, no. We may need to be worried about propofol infusion syndromes in this. The maximum body weight is only 150 kg for a Marsh model. So if the BMI is more than 40 or something like that, it calculates a lean body mass. Divine titration to clinical effect and EEG is a must. In pregnancy, we may need to know propofol is highly bound to maltodextrin, albumin or lower. Hepatic clearance is maximal. All these basic changes of pharmacokinetics in pregnancy we should know. Larger volume of distribution of remifentanil. These things we may need to know before starting this. What is lean body mass? Lean body mass refers to the weight of everything in the body except fat. Now usually it is 25% fat. Now 100 kilos means it is 75 kilos. 25% body fat is more. What I do is 20% less of ideal body weight. What is ideal body weight? Ideal body weight is weight minus 100. Simple. 102 minus ideal body weight. Broca's index. So 20%. If the ideal body weight is coming as 52, okay, 152 minus 100, 52, then 20% less. That is the lean body mass. Now you have an example, a 65 kg patient coming for lap chole for TIVA. Now give propofol, 2 milligrams, around 120, 130 milligrams. Set a propofol infusion of 8 milligram per kg per hour for the first 10 minutes, 4 to 6 milligrams for a titrated dose of 40 to 50. Remifentanil started as 0.2 to 0.3 adjusted to hemodynamics. Now we may need to have a clinical titration scale. This is how TIVA. You can also give a natriuretic, put the tube, start your infusion, and decrease the infusion to 6 milligrams. But in TCI, propofol Schneider model, you have to age, height, weight, sex, etc. 4 microgram per ml is the effector site concentration. Everything start choose Schneider model and keep it at 4, and light anesthesia means that keep it at 3. How to end this? TIVA TCI. Slowly decrease 4 to 2. And just make some people will give more slight dose. Stop, you have to dismantle this. This may not be a clear indicator. This will be around 40 to 50, and suddenly it may not rise slowly 40, 50, 60, 70. Suddenly it will go to 90 as the patient moves everything. That is a major problem of TIVA, awareness. When using a volatile, it may not be there, or it is less. Syringes and infusions will be good lower lock corrections. Hypotension, apnea, propofol, or some infusion syndromes or some side effects. Is the analgesia sufficient? And technology and experience with anesthetics. It is environment friendly, decreased PONP. Patient-centered, rapid onset, monitoring, smooth emergence, lesser hospital stays. We know the major problem is awareness. If everything goes off, the TCA will forget their programming with complete failure. So we may need to start to basics. Sedasis is a computer-assisted personalized sedation systems. There are ITIVA and TIVA managers or computer programs created for monitoring concentrations of anesthetic drugs and guided TIVA. There are closed-loop anesthesia class, make sleepy. Now, CAMTIVA, which I use, is ketamine, atropine, midazolam, and pentazocine mixed and give it.